Assalamu alaikum, everyone. Thank you for the very kind introduction. And I would like to share my slides before making any presentation. I begin in the name of Allah, the most beneficial, the most merciful, and I bring greetings from Karachi to the organizers of the program and to the chairpersons who are chairing this session. I'm thankful to 10th Middle East Endocrine Diabetes Delta Egypt for providing me this opportunity to share my views about postpartum follow-up, a critical window after hyperglycemia in pregnancy. I have no conflict of interest, and I would begin with this very important streetlight effect, a metaphor for knowledge and ignorance. Most of us agree that science is a bit like the joke about the drunk who was looking under a lamppost for a key that he has lost on the other side of the street because he's searching here because where the light is, it has no other option. So we also, being the medical professional and choosing a path and continuing with that path, we tend to seek the evidence where the process of seeking is easier rather than where the truth is. How often we look for solutions in the wrong places. And with this, I would like to present few slides about introduction and then followed by what are the problems in postpartum follow-up. So 119 to 127 million live births per year, according to FIGO and according to IDF Atlas 2025, are from India, China, Pakistan, Indonesia, Bangladesh, etc. 90% of these cases are occurring in low-middle income countries, which account for 90 million pregnancies worldwide. Out of this, 20 million pregnancies are complicated by hyperglycemia in pregnancy, whereas 3 to 4 million are detected and treated. And when it comes to postpartum follow-up, very few receive postpartum follow-up and lifestyle advice. What are the reasons? Let us explore. Talking about the global estimates of hyperglycemia and pregnancy as given by IDF Atlas 2025, as I said, that the global live births in women of reproductive age are about 118 million. 20% is the global prevalence of hyperglycemia in pregnancy, and 23 million births are affected because of this global prevalence of hyperglycemia in pregnancy. The important thing to consider is that the proportion of cases due to GDM are about 80%. And the proportion due to other types of diabetes first detected in pregnancies are about 21%. So we have to take care of these 80% of the cases of GDM to prevent them from adding to these 21%. And this is very, very important. As far as MENA region is concerned, the age standardized prevalence is about 19%. And the number of live births affected in millions is about 3.6 million, which is a huge, huge number. Talking of adults with diabetes in Pakistan, in 2000, 8.8 million were suffering from diabetes. But after the passage of about a quarter of a century, we can see that 35 million people are suffering from diabetes in Pakistan. And Pakistan is one of the 21 countries and territories in IDF MENA region, which has the highest prevalence of diabetes and the fourth highest number of adults with diabetes in the world. Talking of women's age group distribution in Pakistan, 113 million women out of 241 million women are there in Pakistan. And if we look at these figures, about 55 million of these women are in their reproductive ages. As a result of higher fertility rates in younger women, almost half of all cases of hyperglycemia in pregnancy occur in women under the age of 30 years. And as far as the gestational diabetes is concerned, it's a public health concern globally and in Pakistan. Studies indicate a high prevalence of GDM in the region, and the rates vary from 9 to 37%, according to research papers, according to the definition used, and according to the screening criteria. So there is a wide variation in the rates and ranges of GDM in globally and also in Pakistan. Now, timely postpartum follow-up matters for long-term diabetes risk. Postpartum period is crucial, as we all know. Early detection and prevention of type 2 diabetes is related to postpartum period because GDM, it goes away after the delivery of the placenta and after the delivery of the child. But it can pose a risk in the next 5 to 10 years, which we'll just be looking at another slide. So initiating preventive strategies in the postpartum period can have a lasting impact, and women with GDM also face long-term cardiometabolic, obesity, hypertension, diabetes, and other cardiac risk factors in the future life if appropriate intervention is not undertaken. But the problem here is in the postpartum period is that less than half of the women are screened, and global gaps in postpartum glucose testing are enormous. Less than 50% of the women globally undergo postpartum blood glucose screening. And these blood glucose screening rates vary from 6 to 95%, which is a huge variation. In the developed countries like United States, it barely has increased to 58% in the past decade. So there is a wide global variation in postpartum screening, even in high resource settings. We have to address this gap, and it is critical for improving outcomes. This is about a project which was funded by World Diabetes Foundation in Pakistan. It was 3.5 years project, and we had a group of collaborators and authors in this project. And there were findings and challenges from a national GDM project. It was published in Journal of Diabetology. And this was about a mass media campaign for screening of hypoglycemia in pregnancy and postpartum follow-up. What were the major challenges in resource-constrained settings? And we had 3 provinces recruited for this project and 19 sites in Pakistan. And the objective of this project was to reach rural cum urban health systems, to emphasize GDM screening, and to incorporate the importance of postpartum follow-up, besides creating awareness and producing linkages between primary, tertiary, and tertiary care institutions. So we screened 12,000 pregnant women in this project of 3.5 years. The awareness was given in schools and in colleges and universities, and also to healthcare providers. The important part of this project was the postpartum follow-up in these women who were screened during pregnancy. The project data provides real-world insights into the postpartum screening rates and highlights the importance of timing and follow-up systems. So this was the insight from 4,767 women out of these 1,200 pregnant women. And what the lessons we learned from GDM WDF project was that out of this eligible women, who were 4,767, 50% of them, they completed postpartum follow-up. Out of these 50%, 89% were tested within 48 hours when they were still in the hospital for blood glucose screening. However, 11% were screened after 6 weeks, only 11%. And 51% of healthcare or hyperglycemia in pregnancy cases were lost to follow-up. In spite of repeated telephonic reminders, in spite of all efforts, we lost 51% of the cases for follow-up. So the question is that should we have early versus late blood glucose testing? When should we screen the women in postpartum period? The conventional teaching, which we find in all guidelines and we in practice also, that do an oral glucose tolerance test in women who were screened positive during pregnancy for GDM at 4 to 12 weeks postpartum. But then the alternative was to have an OGTT within 48 to 72 hours postpartum when the women are still in the hospital after delivery. And we found that early testing showed predictive accuracy. So recent studies also suggest that early postpartum testing may help stratify risk more efficiently, especially when the follow-up rates are so low, as we just saw in developed world and as we just saw in our own study. So what we found in postpartum glycemic outcomes in practice, out of 2,376 women, that is about 50% follow-up, 81% were found to be normoglycemic, while 2% persisted with diabetes and pre-diabetes was found in 16.8%, that is almost 17% of the women who were screened in the postpartum period. So despite reasonable screening uptake, as you can see that 81% were normoglycemic, a substantial proportion, that is 17 plus 2%, showed impaired glucose levels postpartum, emphasizing the need for long-term monitoring. Now, what are the controversies over timings of postpartum follow-up and blood glucose screening? One strategy was to improve screening rates is to test immediately after pregnancy, during the delivery, hospitalization, and when the woman is still in the hospital, to identify patients at high risk for type 2 diabetes in the postpartum period, and thereby improve efforts to target lifestyle modification and advise them to have at least 2 years of inter-pregnancy interval. So the controversy again over the timing of postpartum follow-up for blood glucose screening continued, and the studies showed a combined patient level analysis of 4 studies with a total of 319 participants compared results of 75 grams oral glucose tolerance test during delivery hospitalization with results at 4 to 12 weeks postpartum. That is, when they were screened positive with 75 grams glucose load during delivery hospitalization, if they were negative here, they were found to be negative at 4 to 12 weeks postpartum for high blood glucose. And this had a sensitivity of 50%, specificity of 95 to 96%, and 98.1% had negative predictive value. So this proves that in-hospital testing, while the women are still in the hospital after the delivery, with 75 grams oral glucose tolerance test, has the potential for risk stratification. And this helps to identify those at lowest risk for type 2 diabetes in the immediate postpartum period. If they are negative while they are admitted in the hospital immediately after delivery, they were negative even after 6 weeks in a small number of women who followed us postpartum. However, the prevalence rates for diabetes in postpartum period varies with the follow-up, with the years of follow-up. Short-term follow-up can tell us about 10% of the women they were positive, while 1-year follow-up showed that 38% of the women were positive for diabetes, type 2 diabetes. And 5-year follow-up showed that 80% of them were positive for type 2 diabetes or were converted into type 2 diabetes, those who had GDM during the last pregnancy. Women with a previous pregnancy complicated by mild GDM are at high risk of developing metabolic syndrome in 5 to 10 years. Although subsequent pregnancies do not further increase the risk, but just one pregnancy and they are at risk of developing metabolic syndrome down the line in 5 to 10 years. Now we have to understand the drop-off. Why women don't return for follow-up? Because of socioeconomic barriers, cost, transportation, and education or awareness. There are psychological factors as well, because of fatigue, looking after the newborn, home chores, then denial that they cannot have diabetes because nobody in the family has diabetes, or the fear of diagnosis that she will be stigmatized. Then health system limitations, lack of reminders, and provider specialty. So by provider specialty, I mean whether they should go to gynecologist, they go to endocrinologist, or to the family physicians. So they are not sure. So this drop-off is multifactorial and has to be understood and addressed in a same way. Now the question is that which women returns and who doesn't? What are the predictors and solutions? The higher education or awareness and insurance coverage may improve postpartum follow-up rates, but still this is not the definitive solution. However, effective intervention, that as we did in our project, that we gave them telephonic reminders repeatedly. There was a special, a person who was employed for this telephonic reminders, which in clinical practice is difficult but not impossible. Better follow-up with obstetricians and endocrinologists. This was again a dilemma for the patients. Whether they should attend their obstetricians, they were happier attending their obstetricians because they think that they know better as compared to endocrinologists or family physicians. Therefore, targeted interventions such as patients' reminders and specialized care significantly improve follow-up outcomes. Moving forward, what are the practical recommendations for better postpartum follow-up? Postpartum follow-up is underutilized despite high risk of type 2 diabetes mellitus because the women who have GDM, as we just saw, have a great risk of being converted into type 2 diabetes. So early postpartum testing is a feasible strategy. So this should be systematically integrated and systematic integration of postpartum follow-up into routine medical care pathways can improve early postpartum testing, and it is a feasible strategy. As we all know, that appropriate screening and diagnosis of hyperglycemia in pregnancy identifies maternal health risks to avoid immediate pregnancy complications. And postpartum follow-up addresses long-term maternal and perinatal health. And we must remember that when a woman is pregnant, she is also pregnant with her grandchild because of epigenetic factors, which most of us know. So again, coming back to the second slide in my presentation earlier, we tend to seek the evidence where the process of seeking is easier rather than where the truth is. The process of seeking is that, okay, all guidelines say do it at 6 weeks of 6 weeks, do the postpartum follow-up or blood glucose testing at 6 weeks of follow-up, at 6 weeks after delivery. So we tend to seek the evidence where the process of seeking is easier rather than where the truth is. And the truth is that women do not come and do not find it easier to come to the healthcare providers for an OGTT 6 to 8 weeks after delivery. How often we look for solutions in the wrong places? So the ideal thing is to have the blood glucose testing at 6 weeks of pregnancy, but let not the ideal become the enemy of the good. And I'd like to inform the delegates present here that diabetes in pregnancy A Journey into Past, Present, and Future of Care, has been published and launched in Faisalabad, Pakistan on 12th of March 2022. And there was another electronic launch by His Excellency Lieutenant General Dr. Sheikh Mohammed bin Abdullah Al Khalifa, Chairman of Supreme Council of Health in Bahrain, with our partners from Bahrain, Dalal and Dr. Mariam Al Ajeri and Nadima and other friends. And this book was electronically launched in Bahrain. Forward contribution and oration by President Saidiev is already incorporated in the book. And I thank you, authors and editorial board, for the insane amount of time, dedication, inspiration, and motivation which was put to complete this book. And this book has a very good chapter on postpartum follow-up. English version of the book was available on Amazon for a price of $250, but from 8th April 2025, this has been made free for all healthcare providers. It has 135 authors from 25 countries and 61 chapters. This is a QR code which you can scan and download the whole book in your mobiles. And the MBs are very much compressed. It's not going to overload your mobile. There's another version which was launched in November 2024 by our friends Dalal, Dr. Mariam, and Dr. Nadima in Arabic version. And this is the QR code for the Arabic version for our friends from MENA region. I thank you all for your attention, and I'm also very much thankful to our friends from MENA region, from DAS, to provide me this opportunity to share my views and to share a little bit about postpartum health and its need. Thank you very much.